Documentation is important stuff because, like I said, when you go to court, if it's not on paper, it didn't happen. So I can't stress enough how much documentation comes in play when it comes to things you do out in the field. All right, so definition: preparatory applies fundamental knowledge of EMS system, safety, well-being of emergency medical technician, medical, legal, and ethical issues to provision of emergency care. I'm not gonna hit hard on definitions. We're roll through it. All right, so when you communicate with patients in a manner that achieves a positive relationship, right? You don't want to go up to them and being being ill, being grumpy with them. They're not going to want to talk to you. So learning different interview techniques to be able to pull different information out. Adjust your communication strategies for age, the stage of development, patients with special needs, and differing cultures. There's very much, when you come to a small kid, you standing over a small kid like this, they're not going to want to talk to you, right? They're going to be pretty intimidated. So get on their level, get down on the knee, talk to them. You might have to do the whole baby talk, like I talked to my 3-year-old. Everybody's talking to small kids, so you can't talk to them the same way you can talk to a 40-year-old grown man. So there's definitely, when it comes to cultures, the United States is a melting pot, right? There's all kinds of different cultures, all kinds of different world beliefs. There's all kinds of different things out here. So you might be asking questions. Be careful of what you're saying because you can offend somebody with their culture, but you also have to get answers that you need, right? So kind of take that into account whenever you're doing this stuff. Verbally diffusing strategies. There's going to be a lot of people out here that don't want to go to the hospital. They don't want you to treat them. So you need to talk to them. Just calm, cool, collected, right? Let them know you're there to help. Let them know that you're not there to, whether it's a car wreck and they've been drinking, you're not the cops. You're not there to arrest them. Like, you're just there to help them. You're there to make them feel better. Family presence issues you'll come across. Children don't want to tell their parents stuff, right? So you run that I lost it. Behavior call with the teenager. They might be going through something that they don't want their parents knowing, right? The parents might insist on being in the room, but again, you're not the cops. You're there to help. Hey, let's go out here and talk. Let my partner talk to them, because they'll be more willing to talk to you potentially with their parents out of the room, right? And we all fall into HIPAA, right? So that's one thing. It's like talking to your counselor, talking to your doctor, kind of thing. So just take that into account when you're looking for stuff. They might be embarrassed, or husband and wife, maybe one of them cheated, something happened, they don't want their spouse to know. They talk to you, so they're in the room. You gotta think about things like that. So with the EMS system, communication. So you need, like we're talking about environment assessment, right? Do we need to call for resources? Where we're transferring care of patient, you're not really calling out on the radio. I'm not radioing it saying I'm giving it to Logan. Like, I'm not doing that. But so your interactors, your team structure, your EMS communication with other healthcare professionals, and team communication and dynamics. It all falls under this category. Questions on that? All right. So your documentation, you record your patient findings, and then your principles of medical documentation and report writing. So anybody remember writing like essays in school, short stories, stuff like that? It's pretty much what you're doing here. You can go as detailed as you want. You can go as least detailed as you want, but like I said, just remember, if you underwrite it and don't put in all the details, and it goes into court, it doesn't matter what you say. If it's not on that face paper, it never happened. All right, medical terminology. Use foundational, anatomical, and medical terms and abbreviations in written oral communications with colleagues and other healthcare professionals. So you can talk to a doctor in one way. You can tell him, they're posterior to this and anterior to that. But you go out here and talk to mom, you're not going to use that same language, right? So you need to change that to who you're talking to, making sure you're talking at the appropriate level for whoever your audience is. Good. And if y'all need to write stuff down and I'm going too fast, just tell me, I'll go back. All right, so communication is the transmission of information to another person, whether it's verbal or nonverbal. Everybody in here is seeing the body language. Everybody can read body language to an extent, right? You know if somebody's mad or something's about to go down. That goes in your scene safety too. Reading body language is a big deal when it comes to certain calls. You'll see people kind of hiding out in that corner, right? Being real quiet, staring you down. They just give you that vibe like, hey, I'm probably not gonna put my back to them, kind of thing. Like you got to take that stuff into thought whenever you're running these calls. Verbal's easy, right? I'm talking to you, or you're yelling at me, calling me a piece of crap. You're gonna do this, whatever the situation is. Verbal's easy. Verbal communication skills are important and able to use to gather critical information, coordinate with other responders, and interact with other healthcare professionals. Obviously, if I'm trying to give a patient handoff to Bentley here, I'm not going to sit here and just look at him. He's not going to get nothing out of it, right? You got to talk to him. Again, if he's my patient, I'm not just going to stare at him and all the information is just going to like come at me. You got to talk to people. If you're not comfortable talking to people, get comfortable talking to people because that's your job or got to be your job. And again, the longer you do this, the more you'll be able to kind of tailor your questions off their answers. Right now, you're going to sound like a robot because you only know what you learned in class. But the more you get into it, the better you'll be, the more you'll pick through stuff. All right, so with documentations, the patient's permanent medical record, that's all on the computer nowadays, especially if they are a frequent flyer. All that stuff's in their computer. Usually, they have a copy of their last hospital visit sitting close to them, and that the spouse says, here you go, this is their last hospital visit. It's got all their medications on it, all their past medical history on it, date of birth, all that information you're trying to get is usually on that paperwork. So if they hand it to you, you can use that and kind of get your information that you need. You got to demonstrate that perfect care was delivered. Like I said, you got to document it. If you had an asthma patient and you gave them albuterol, but you didn't document it, you didn't give them albuterol. And if they died because they wouldn't respiratory arrest, then it goes to court, and then lawyer comes up and says, hey, why didn't you give them albuterol? You're like, I did. Well, it's not in the paperwork, so you didn't do it. So now guess what? You lost your license because you didn't practice. You didn't function correctly. Also helps others in patients' future care. So we have a patient in our territory that is a frequent person, but they have COPD, and we know when we go out there, they don't call unless they're in rough shape. So when we get there, 95% of the time we're putting them on a CPAP. But we know that because it's been documented. We can see the history when we run that house. Hey, every time we've gone out there, this is what we've always ended up having to do. So we can kind of keep up with that. So we already have a game plan when we walk in the door. So you complete patient records, guarantee proper transfer of responsibility. It complies with requirements for health departments and law enforcement agencies, and fulfill your organization's administrative needs. Questions? All right, computer, radio, and telephone communications. Your EMT, the EMS, fire department, law enforcement. That's how you all talk to each other, right? We're not picking up the cell phone and calling each other. We're not sending carrier pigeons anymore. Get on the radio, call each other, talk to each other, let you know what you need to know. You must know what your system can and cannot do and how to use the system efficiently and effectively. Some systems out here can talk all the way across the state. Some of your smaller departments that might not have the radio system that's able to do that. So you gotta know what you can do. Especially that comes into play when it comes to like storm mode. We get a lot around here, right? So when you don't have the main dispatch, you have to talk on your back channels, or any kind of like mass event when there's multiple channels involved in it. You need to know what you can do and what you can't do. All right, use various communication techniques and strategies, both verbal and nonverbal. We talked about that. Encourage patients to express how they feel and achieve a positive relationship with each patient. You're trying to build that rapport with them. You're trying to get them to talk to you, make them feel safe to where they'll explain what's going on with them. Shannon-Weaver communication model. It comes out, the sender takes a thought, encodes it into a message, sends the message to the receiver. receiver decodes the message, and then sends the feedback to the sender. Does everybody understand what they're talking about with this? If you don't, just say no. Thanks, sir. So we're good on that? Yeah? Yeah. I mean, think of just having a conversation. That's all it is. All right. So that's your model right there. All right. Factors and strategies considered in communication. Age, body language, clothing, culture, education, environment, eye contact, facial expression, sex, posture, voice, tempo, volume. It is a very different conversation when I'm sitting here and we're sitting here talking. We're talking just like this versus I'm sitting here yelling at you, putting my hands in your face, doing this number, right? Two different conversations. Two different body languages, two different volumes. So take all that into account. The posture thing, like I was saying, the guy's kind of hung back in the back with his fist in the ball behind his back. Take that into account. Culture's a big one. There's some cultures out there where men are not, if you are not married, you're not allowed to talk to the wife, right? Like the wives aren't allowed to communicate with other men. So you have to, they might not talk to you, but it's not because they're trying to be rude. It's just because in their culture and their beliefs, this is what it is. So you might only be talking to the husband. Age, little kids, old people, you might have to raise your voice a little bit for the older generation. Eye contact, some people might be awkward if you're staring them in the eye. Some people like, my engineer does not like you looking at him in the eye when you talk to him. He will not look at you in the eye when you talk to him. He'll look at your nose. Found that out yesterday. But because he feels uncomfortable having eye-to-eye contact with somebody. So just take that into account when you're talking to people. Education. Some people are on different reading levels, right? Keep that the nicest way possible. So you try to use all these big words at them, they're not going to understand what you're saying. So bring it down to where they can understand you. All right. Talk about this. Your age, culture, and personal experiences influence how a person communicates. Easiest way to explain that, you got a southern person, you got that southern drawl. Somebody from the north, you got that Yankee slang, right? So there are two different ways they talk. Words that mean completely different depending on where you're at. Body language and eye contact are greatly affected by culture. In some cultures, expressing emotion is weakness. In other cultures, it's impolite to look away while speaking. So take that into account. You don't want to disrespect anybody, but also if you can't handle what you don't know, right? If you don't know, it is what it is. Do your best with what you got. Don't intentionally disrespect somebody just because you think whatever they believe in is stupid. That's irrelevant at that point. You're there to treat them. You're not there to judge them on whatever their beliefs are. Your tone, pace, and volume of language reflect the mood of a person and perceived importance of the message. If I come up and I'm just like, hey man, you should probably do this, you're not going to think it's that big of a deal, right? But if I'm like, hey man, I need you to give that to them right now. There's a little bit more urgency behind that stuff, right? So use that to account whenever you're working on this. Consider your own cultural values and more important than those of others. You're out here to help people. You're not above anybody. You're here to help. You're here to do what you need to do. So the culture imposition is forcing your values onto others. Again, your beliefs does not matter out in this field, right? There's some religions out here that do not like, you're not allowed to take medications, or you're not allowed to get other people's blood, right? Just because you think they need a medication, if they're telling you, hey, that's against my beliefs, doesn't matter what you think. That's up to them. That's their choice, right? If they don't want you to do it, then you don't do it. You're not trying to force anything on anybody. All right, so with nonverbal communication, your body language provides more information than words alone. Even without exchanging any words, you can be able to tell the mood of your patient. We all know body language. We've all seen it. You can all tell when everybody in here, when they get in a bad mood, their body language changes, right? You might put your arms like this, or kind of have that face on you. We're like, oh, he's not happy right now. Same thing. Look for that. Facial expressions, body language, and eye contact are powerful communication tools. It helps people understand messages being sent. I feel like I beat this like a dead horse at this point when it comes to body language and eye contact. So if you don't have any questions, we're going to keep moving past that. Sweet. All right, when treating a potential hostile patient, be aware of your own body language, right? So if Kimbro's all bent out of shape and he's hyped up, he's ready to fight, I'm not going to go in there fist drawn like, hey man, like, nah, I'm going to try to go in there, I'm going to calm, be relaxed, keep your hands down, right? Don't give them that impression where you're there to square off with them. Because they're already on edge, they're ready for a fight. So you got to look at that kind of thing. You stay calm, try to defuse the situation, assure your safety, right? The big thing there is do not, if you're in this environment, do not put yourself between, do not put the patient between you and the exit. Try to keep the patient away from you and the exit. You always want to exit behind you or somewhere close to you that you don't have to go through your patient to get there. So if something escalates, you can get out. Case in point, I'm the hard way. I had a call not too long ago. Luckily, the guy was pretty calm. He was pretty laid back. He wasn't meaning anything threatening by it. He was just hiding it. But it was me, him, the front door. And that's how it was. I was in his living room. We was getting him ready to walk out to the stretcher. And next thing I know, I see him reach down beside his little chair, and he pulls out a pistol and puts it right in my face. And I was like, oh, no. And I was like, hey, man, you can't take that with you. And he's like, oh, I'm just putting it away. I was like, all right, let's do that right now. But immediately I was like, back on. I teach these kids not to do it, and guess what I did? I did the same thing I teach y'all not to do. So just be aware of it. It happens without you thinking about it. My guard was down. We'd already done the case of care. He was leaving. He was a pretty chill guy. I didn't think nothing about it. Granted, like I said, he wasn't threatening me with it. He was just hiding it. But still, somebody pulls a gun up. All of a sudden, I know we were not expecting it. You're like, whoa. Like, hold on, back up. Let's figure this out. So do not assume aggressive posture. Make good eye contact, but do not stare. Speak calmly, confident, slowly. Never threaten the patient either verbally or physically. Pretty self-explanatory, right? You're there to help. You're not there to further cause problems. All right. Physical factors. Literal noise or sounds in the environment, lighting, distance, or physical obstacles may affect your communication. Construction sites, it's loud, it's moving. Clubs, you go to clubs late at night, it's loud. They got face bumping like crazy. Pedestrians walking around. Those are going to be things hard to hear. The culture norms often dictate the amount of space and proximity between people when communicating. And then gestures, body movements, and attitude towards the patients are critically important. Like I said, keep your body to relax. You don't want to give them any kind of threatening tone off to them. You don't want to give them the attitude because then they're just going to shut down. Asking questions is a fundamental aspect of pre-hospital care. Open-ended questions require some level of detail. Example is like, what seems to be bothering you? That's going to give them the option to explain everything that's happening to them, right? Like if I go up to you and I just say, hey man, does your arm hurt? You might say no, because your stomach's hurting, right? But if I come with, hey man, what's going on? Like what's hurting? That's giving you the option to explain what's hurting. It's not just narrowing down on one thing. Closing-ended questions. Is your arm hurting? Yes. No. Short answers, like to the point. Are you having trouble breathing? Yes. No. Yes, no questions, that kind of thing. All right. Communication tools, facilitation, pause, reflection, empathy, clarification, confrontation, interpretation, explanation, and summary. All right. When interviewing a patient, consider using touch to show caring and compassion. Use concisely and sparingly. Avoid touching the torso, chest, and face. Why would you want to touch those areas? Sexual harassment, right? Very much can get yourself in trouble. I steer away from touching to the most point. If I'm touching, I'm going to come up like, hey man, I'm going to do this, right? My hand's on your back. There's clear as day. I'm not meaning anything by it. I'm just trying to talk to you. I'm trying to help you feel better. Now, if I do this and they do that, all right, cool. I'm not gonna force you, right? Like I'm gonna keep my distance from you. Obviously, you don't want me touching you. Oh, very much of like, hey man, is it all right if I touch you? Is it all right if I like check this out? Get their permission first, right? Ask them. But you can use this. Elderly patients, I find this a lot of my elderly patients. A lot of times they just want somebody to talk to. somebody to feel like they care about them. So that works very well with them, especially in the back of the ambulance. Like you said, you can hold their hand. Hey, it's okay. We're gonna help you. I had I saw a wreck the other day happen in front of me, and I had to get the girl out of the car. And as I was getting her out, her thing was she was putting hands on me, right? Like grab my shoulders, grab my arms, or whatever. Now it is what it is, because that was making her feel comfortable. And then once I got out of the car, it was, hey, I sat there and I literally was holding her hand, talking to her, trying to get her to calm down. She was fine with it, right? I wasn't forcing anything on her, but that was helping her feel like somebody was there until fire showed up, EMS showed up, things like that. They could take over the patient care aspect of everything. So what you don't want to do is don't get false assurance or reinsurance. I know it's hard, but don't do everything's gonna be okay, or like when it's really not. Like, be straightforward. Don't lie to them. Giving unsolicited advice, they don't care about your opinion. They just want you there to fix it. If they need your help, they don't care how you feel about it. You want to add something? Oh. Asking leading or biased questions. Don't let your own influences affect on how you do your patient care. Don't just because you want it to be something, don't try to get that questions to get there. Make sure you're getting the whole picture. Don't talk too much. Let them tell you. Don't interrupt them, right? If you start to interrupt them, they're gonna be like, well, man, this guy don't even care what I have to say. I'm just not gonna say anything. Using why questions, using authoritative language, and speaking in professional jargon. Like I said, your patients are not gonna understand you if you start talking posterior, anterior, distal, proximal, this, that, like quadrant 1, 2, 3. They're not gonna understand that. Hey, does your belly hurt? Where's your belly hurt? Talk to them in language they're going to understand. All right, your friends and family may be valuable during the patient interview process. Small children, like I said, they might want mom and dad there, so let them be there if they need to be. Friends will be there. Some people feel more comfortable if they have somebody with them that they know intimately, where they might not know you. So you allow your patient to answer, even if well-meaning family members attempt to answer the question for the individual. It happens all the time, especially with children. You start talking to them, and mom or dad wants to answer. Hey, mom, dad, I appreciate it, but I really need them to answer. I need to get answers from them, right? So even the older patients, it happens again. You get your older geriatric patients that are living at home with their kids, right? You run them, well, son, daughter, want to tell you about all the different procedures they had and all the different health aspects they've had and what they think's going on, because it happens. But hey, I appreciate it, but I need to talk to them. I need to hear what they have to say, right? Don't be afraid to ask others to step aside for a moment. I've done it. Don't be afraid to do it. Hey, I need you to step over, get your partner. Like, hey, can you get them out of here for a second? I need to be able to talk to my patient. Cool. Hey, let me talk to you for a minute. Can you come find? There's ways around that you can have somebody step away, but it doesn't feel to them like you're trying to take them out of the situation. And it also gets you information you need, right? Like, you can get patient information from them, date of birth, name, stuff like that, medications from those people usually, and then that keeps them from interrupting what your partner's trying to do or you're trying to do with your patient. All right, so make sure you keep golden rules. Make sure you keep eye contact at all times. Again, don't stare. Like, I'm not just sitting here staring at you, because that just makes you feel super awkward, right? Like, you won't even look at me in the eye right now. You're looking down. So, like, don't. But I can keep eye contact and talk to you, and it be not awkward. Provide your name. Use the patient's proper name. Hey, I'm Travis. I'm an EMT. I'm with ABC department, right? I'm here. What's going on? What's your name? Oh, I'm Susie. Okay. Susie, what's going on, right? Or older patients, if you know them, different generation, they might not like being called by their first name. So, Mr. and Mrs. Johnson, what's going on? Like, it's a respect thing, right? The older generation. Just different times they grow up on, so you got different things like that. Tell patients the truth, don't lie to them. Don't ever lie to your patient. It's a big thing for me. If they're in rough shape, hey man, I got my rough shape, I got you. Do the best I can, right? Don't lie to them, especially if they ask you. Don't lie to them. Using language the patient can understand. I'm going to beat that one. Be careful what you say about the patients to others. A, HIPAA, don't give information out that's going to wind you up in jail. Of course, lose your license. Be aware and then be aware of your body language. You don't want to give threatening body language off. You don't want to give the body language off that they're a nuisance for you. They're a nuisance to you. Like you don't want to be there. You'd rather be at home, sleep, watching football, whatever that is. Eat nachos, whatever you got there. All right, speak slowly, clearly, and distinctly. Don't use unnecessary. Don't just start talking about flowers in the park. Don't start talking about random things. Be clear in what you're saying. If your patient's hard of hearing, face it patient so they can read your lips. Most of them can. Don't just start screaming at them. Allow the patient time to answer or respond. Act and speak in a calm, confident manner. Remember, you are the professional. If you're freaking out, they're freaking out. Whether you're freaking out on the inside, you're like, oh crap, oh crap, oh crap. Don't show it on the outside. Like, if you need to step away, let your partner know, hey, I need a second. Or your supervisor, hey, I need a second. Because there's calls that happens. You're going to be like overwhelmed with things going on. There's going to be God knows what, right? Like multiple bodies, whatever the case may be. And you might have to step away because your brain just can't process it. Let somebody know. Don't freak out in front of your patient. All right. We'll go for like 5 more minutes. I'll give y'all a break. Cool. All right. So your ability to understand and manage your emotions properly, respond to others' emotions. It helps with diffusing conflict, building rapport, communicating effectively, and managing difficult situations. Again, this is you learning how to manage yourself and be able to deal with that. Develop, letting you in, giving the information you know to treat them. So attributes of emotional intelligence is self-awareness, self-regulation, motivation, empathy, and social skills. Like I said, this job is very social, whether you're an introvert or not. I know plenty of people in this job who are introverts, but they're very good at talking to people. They've learned how to adapt that social skill when they run calls. They can have a conversation with you better than most people and be able to talk, but as soon as they get in their truck, they're done. They don't want to talk, right? Like it is what it is. But you have to be able to develop that social skills aspect to be able to have a conversation with somebody, even though you feel awkward doing it, especially somebody you don't know. That has to get out the window. You have to figure out how to get over that. Motivation, I correlate that to, wanting to be good at this job, right? Wanting to do the best you can. You're there for a reason. Like I said, you're the professional. You're there to help. So be good at it. Have that motivation to you want to be good at what you're doing. Empathy, you're feeling for this person, right? Whether it be you're going to nail down a carpet and whatever, because they're a little bit on the bigger side and they can't do it. Just I got you. Don't worry about it. Don't make them feel like they're a nuisance for you. All right. So improving your emotional intelligence. Assess how you react to a stressful situation. You practice your mindfulness. Focus attention on the present moment. Take responsibility for your actions. Consider how your actions will affect others. Think about things. Debrief. That's a big thing. Whenever you run a call that you think might not have gone too well, or you think you could have done better, come back and debrief it, right? Break it down. Figure out, do a hot wash on it when you get back. Whatever terminology you want to call it. Break it down. See where you struggled at. See where you feel like you can get better. That's only going to make you better because then you're gonna recognize it. You start doing it again and be able to change it in the moment. Behavioral change steroid model is developed by the FBI to manage hostage situations. It's adapted for crisis management. Employ active listening, display empathy, build a rapport, exert influence, initiate behavior change. Right? Employ active listening. We've talked about that. Don't overtalk them. Let them talk. Listen to what they have to say. Display your empathy. We talked about that. Build a rapport. That's the biggest thing, right? You have, because they might talk, Bentley might talk to me, but not talk to Kimbrough because I built that rapport with him. When Kimbrough said, "Hey, man, I don't want to be here." Like he just gave off that body language that he didn't want to be here because it's 2:00 in the morning. He'd rather be at home to sleep. exert your influence, and then initiate behavior change. When it comes to special behavioral patients, you can a lot of times talk them down. They might be on running, on stop mode for a little bit. Talk to them, ensure they're there to help, get them calm down, and eventually you can start seeing them come down occasionally. We're gonna talk about that. Identify yourself. Hey, I'm Travis, Logan, whoever. I'm an EMT, I'm a fireman, whatever your job is. I'm with ABC department. Let them know that you're there. Present yourself as confident. Remember, you are the professional in this situation, so you're there to help. So present yourself as what? I would much rather have the guy come up and be like, hey, I'm such and such in this department. What's going on? And be very confident. You talk to them. I tell them, hey, they're not feeling good. All right, cool. Where's it hurt? Confident in your treatment versus like, hey, I'm Travis. I'm an EMT. I'm with this department. Why are we here? You all right? You know what I mean? Like, I'm not going to be very confident in your patient care, right? Like, especially if that's my kid, I'm like, you know what? I'm good. I'm just going to load him up. Like,
I'm just going to throw you out the house until send somebody else.
Yeah, exactly. Like, you're not giving that confidence that you're the professional in the situation, right? Just think about it. 90% of the time, if that phone rings or that bell dings, it's somebody's worst day they possibly could think of, right? So when you show up, you are there to be the expert, to be the person to help. If you show up not confident in yourself, whether you're freaking out on the inside or not, if you show up not confident and they see that, they are not going to feel good with you treating their family member or them. I've had partners in the past that literally the patient has been like, I don't want you to touch me, because they just blanked and had no idea what they were doing, and it showed. And they can't do that, and then you're SOL, right? All right, so do not assume that all the patients see now we're confused. We all got grandparents that have dementia, at least mine does. It's very easy to put them in that bubble, but there's plenty of them out there that aren't in that bubble. They just literally might be something. Sugar's a big thing. UTIs are a big thing. UTIs are a big thing in older generations, and when people have UTIs, they can have it off a mental status. So don't just assume that they are out of their minds. All right, you may encounter hostility, irritability, and confusion. Do not assume this is normal behavior. Approach the older patients slowly and calmly, and allow them plenty of time for the patient to respond to your questions. This happens a lot. They might be upset that their body is not working the way they think it is, and they're not willing to accept that fact. And they get very angry. And then you got little, how old are you, Jose? 18. So you got little 18-year-old Jose walking in, telling 70-year-old Bob, who was in the military, special forces, or a trooper, or some just guy. They're like, hey man, little 18-year-old Jose's telling him what to do. He's not gonna want that, right? Might take a little bit to get there. Watch for signs of confusion, anxiety, or impaired hearing and vision. Like I said, if they can't hear very well, try to get in front of them, let them read your lips. The patient feel confident that you are in charge and that everything that's possible is being done for him or her, and be patient with them. You don't want, like I said, you don't want them to feel like a nuisance. The older patients often do not feel much pain, so you may not be fully aware of the important changes in their body systems. You must be especially vigilant for objective changes. So just watch them. They've been through the ringer. They might, what's a 9 for Jose might be a 2 for the Bob, who's been shot 5 times and stabbed 10 times and jumped out of airplanes and helicopters for the last 50 years. Pain scales might be different. So just watch for those kind of things. That's what's important, to know your body, know how it works, and be able to pick up on those changes. All right, so when possible, give patients time to pack a few personal items before leaving for the hospital. Let them get their wallet, their phone, their keys, things like that. Assure them, hey, I'll lock your door for you, whatever. You know what I mean? Let them get those couple things. And now if it's life-threatening and they got to go, it is what it is, right? Like, I'm not going to let you die because we want to take your keys. But if they got time to get their keys, let them get it. Or while you're loading them on, have fire. Or be like, hey, while fire's helping you, where are your keys? Where's your wallet? I'll grab it. You have a purse you need me to grab, whatever. And just my 2 cents, if you're going to grab something like that, take somebody with you. Like, just have two people with you, especially if you have to go out of sight of people. Just so that way, if something's ever said that, like, hey, he still want, I had $100 in my purse when I set it down, and then when he gave my purse, I didn't. You at least have one person there to help you, like, fight that accusation, right? Not saying it happens, but it's just kind of like a CYA thing for you, right? Just be aware of it. Be aware of that kind of thing. Same goes for treating, in my rule, treating like, if you're like a male treating a female patient, do your best to keep somebody in a room with you, right? You don't want any kind of claims against you, and vice versa. If you're a female treating a male, have somebody else in the room with you, right? Just do your best not to be by yourself in these situations. So look at hearing aids, glasses, dentures before departure. Hey man, sometimes grandma won't look good going to the ER. I've had plenty of older women that's like, hey, let me brush my hair first, because that's what they care about. They don't care that they're about to die. They want to brush their hair. They want to look pretty in the ER. Older patients are often worried about the safety of their home, valuable items and pets. Assure them, hey, we'll put your dog up for you. We'll lock your front door. Don't worry, we got you. You just need to worry about getting better. Go, let's get on a stretcher. We'll handle everything for you. If you need to call a son, daughter, whatever, I did that. Had daughter come and help me lock the house up and stuff like that. Fears most obvious and severe in children. Who's got kids in this room? Anybody? No? All right. So I know a lot of y'all are young. The scariest thing you'll ever find, to me, is when a kid is terrified and you don't know what to do to help them. You gotta do what you can. All right. So children might be frightened by your uniform, the ambulance, and a crowd of people gathered around them. Again, if all of us are gathered around Jose and we're all yelling and moving and touching and trying to help him out, it's gonna make you feel uncomfortable, right? You probably feel uncomfortable with me just kind of standing over top of you like this a little bit, right? Yeah. So same thing for kids, right? So if it's a 7-year-old, well, I can guarantee you, my 12-year-old, if 4 or 5 people go around her, she's gonna shut down. She is not gonna talk to you. She wants no part of it, like none. My 3-year-old, she's close to that same way. She'll be a little bit better, but she's the same way. Your ambulance, you gotta think about it. It's loud, it's bright lights, the engine's running, doors are slamming, things like that. So, and then your uniform. Go back to cultures. Some cultures feel a certain way over uniforms, right? Call it what it is. They might see you. When I worked in a county, our uniforms were close related to another agency's uniforms. A lot of times people thought we were them, and they didn't want us to talk. They didn't want nothing to do with us until we explained, hey, we're not them. We're EMS. Let me help you out, right? So be aware of that. Like this, it's a very real thing. So let a child keep a favorite toy, doll, security blanket. Let them take the teddy bear. They're whatever. Like if that's what's gonna make them feel comfortable, let them. That's what's gonna help them out the most. If possible, have a family member or a friend nearby. We talked about that. That's gonna help them keep their guard down. They're gonna feel safe in that environment. Let the parent or guardian hold the child during evaluation and treatment. I do it all the time. If it's a small kid and they're freaking out, hey mom, dad, if they're holding mom, because normally they're gonna be holding mom or dad, right, or brother, sister, whoever they feel comfortable with when you walk in, and if that's the case, treat them like that. There's no need to rip them out of their arms to treat them. Like, you very well could treat them like that if that's what's keeping them calm to be able to do the treatment wise. Be honest, children can honestly see through your lies and deception. They ain't stupid. They might be young, they might not be here this long, but they're not stupid. I can promise you, my daughter calls me out on my BS all the time. They know when you're trying to pull something over their eyes. Tell them ahead of time if something hurt. If I'm over here assessing Bentley because he fell and his arm's talking about it's gonna hurt, and I'm going back to pull, I'm not gonna be like, hey man, this isn't gonna hurt at all, and then I'm gonna move them and then it hurts, and now I lost all trust right there. I'm done. There's nothing else that kid's gonna let me do. Same thing if you're trying to take a sugar. If you tell them it's not gonna hurt, and then you stab them with that, you poke them with that needle, and it hurts them, you're done. You lost all trust that kid's ever gonna have for you, and maybe future people coming after you, right? So think about that. It's not just about now, it could be about the future. Respect the child's modesty. So speaking of a professional, friendly way, maintain eye contact, position yourself at his level. We already talked about that. Kids don't want you hovering over them, get down on one knee, get on eye level with them, talk to them. Let them know you're there to help. You're there, professional but friendly. You're not over here like, oh, this is little boo boo hurt. You know what I mean? Like, you're not talking to them like they're a baby, but talking to them, hey, what's up, little man? What's going on, like? You hurt your arm? Ah, man, I know you fall off your bike. Like, talk to them, right? Just have a conversation with them. Like, is it okay if I check that? Is it okay if I look at it? Are you good with it? I promise I'm gonna do my best not to hurt you, like if I can, right? But I really need to check you out. Are you sure? It's okay? Just talk to them. They're not stupid. They'll have conversations with you. So most have normal intelligence that are not embarrassed by their disability. Just because you might feel awkward talking to that kid who's not 100% there, who's got some type of birth defect, they've had it their whole entire life. To them, it's normal. Don't treat them different. You know what I mean? Like, if it's not different treatments, treat them the same you would treat a healthy 10-year-old. Because you know what I mean? Like, it's the normal aspect of things. So you have to treat them that way. Position yourself so the patient can see your lips. We already talked about that. Hearing aids, be careful that they are not lost during an accident. They might have been forgotten. The patient is confused. Ask family member about the use of hearing aids. Most time that's going to be, you'll see kids you'll see a lot of cochlear implants now. They might not work. So you just got to kind of pay attention to that. If the kid's acting like they really can't understand you, ask the patient or ask the parents, especially if you don't see one. Steps to help effectively communicate with patients who are hard of hearing. Write it down. They can usually read. They can see. Patient can read lips. Face the patient. Speak slowly. Never shout at them. I'm not sitting here saying, Bentley! It just kind of makes that annoys people, right? Nobody wants to get yelled at all the time. All right. Listen carefully. Ask short questions and give short answers. If they can't hear you, you're not trying to give some long, drawn-out thing. Like, make it simple for them to answer you. Give simple sign language. Everybody can tell me what those usually mean. Like, stomach hurts, right? Your head hurt, your stomach, where does it hurt? Point to the body, right? Ask the patient if he or she can see at all. Visually impaired patients not necessarily completely blind. Expect the patient to have normal intelligence. So you're seeing somebody with them thick old glasses, like an inch thick. If they ain't wearing their glasses, they can't see. When you put them glasses on, they can see, right? So talk to them, figure out what's going on. Explain everything you're doing as you're doing it, especially if they can't see, they go off feel, right? So any touch they feel is going to be amplified for them. So because if you lose one sense, what happens to the other senses? Yep, they get stronger. So take that into play. All right, so stay in physical contact with the patient as you begin care. That way they know you're there, you're not abandoning them, they're not going to freak out. The patient can watch the ambulance, place his or her hand on your arm, and then transport mobility aids such as a cane with the patient to the hospital. Because, you might take them in a stretcher, but they got to get home somehow, right? So if they need their cane, if you can get their walkers in, I've pulled the walkers down and put them in the back of the ambulance before. Just whatever you can do to make their life easier on the backside of it. Guide dogs is easily identified by special harnesses, and if possible, transport dog with patients. It alleviates the stress for both patient and dog. Otherwise, arrange care of the dog. They're more and more common now. Now there's a difference in emotional support animals and like the guide dog, like for blind people, right? Just to take that into account what you got. All right, you must find a way to obtain a medical history. Find out if the patient speaks some English. These are non-speaking patients. Use short and simple questions. Point to parts of the body. Have a family member or friend interpret. West Salem's melting pot, people. There's plenty of areas in my territory where there's a language barrier, right? So might not be a bad idea to at least learn some basic form of a second language, the prominent second language in your area, right? So you can ask basic questions or use a sign language, right? And just, like I said, have friend or family member. 9 times out of 10, if we have families with non-speaking family members, it's usually the kid that speaks English because they're the ones that go to school here. They've learned English as a second language. So, and they might be 6, 7 years old, but they're the ones interpreting for mom, dad, brother, sister, aunts, uncles, grandmas. So again, use language that they can talk about. Consider learning some common phrases in another language that is used in your area. Pocket cards that show pronunciation of terms that are available. Use a smartphone app or website. Help you translate. Anybody ever use Google Translate on the call? I have. Very much so. You gotta do what you gotta do, right? We got a computer in our hands, in our pockets, 24/7. Use it to your advantage nowadays. Remember to request a translator at the hospital. Let them know, like, hey, they don't speak English. You're gonna need a translator to be able to talk to them. You can do that on your encode, right? Or when you get there and you're talking to a charge nurse, let them know. All right, communications where a disruption may result in failure of the task at hand. These are mission critical communications. You share a mental model. A mental model is a picture of an individual has in their head of what's going on, and all team members must share that mental model. If we're all working together on this call, but you're you're thinking one way and you're trying to go one way, you're thinking one way and I'm thinking one way, and we're all pulling different ways, 90% of the time we're going to be fighting against each other. We're not going to accomplish anything. Stop talking about it. For all the firemen, think about Mayday situations, right? Y'all all went through fire, most of it, right? So if one of you went down, if Logan went down and all of y'all were trying to go get him, but all of y'all were trying to do a different way, you're trying to go out the window, you're trying to go out the door, you're trying to take him through the attic, you're trying to go cut a floor in the basement, y'all aren't accomplishing anything. Logan's in there cooking, dying because all y'all are doing different things. Somebody's got to take charge and be like, hey, here's the game plan. This is what we're doing. You go bust the window, you hook them up to air, you package them, you're dragging, let's go. Right? All you got to share that same idea of what's going on. Questions to answer. What is the focus priority of this patient? What is the history of prior care, current state, and patient's immediate needs? Primary assessment, right? ABCs, fix those. What's the priority? Like I said earlier, our patient with COPD, that we put them on a CPAP 90% of the time when we go. And does this current state for them, do they need the CPAP right now? Are they good to keep rolling? Let's take a break. Take 10 minutes.